It's a real pleasure for me to introduce our next speaker, not just because he's an ardent Red Sox fan, and not just because we've known Jerry for a long time and seem to see him at the same meetings all the time, but Jerry has undertaken a task which needed to be done, and I'm thrilled with the job that he's done. First of all, he's been one of the biggest resources for the CDC and all their educational material. His hands are all over most of them. But he has taken on the task of, you've heard about the neuropsychological tests and you've seen impact. He's taken on the task of bringing this down to be useful and usable by our youth, and especially individuals under the age of 10, 11. So it's with great pleasure that I introduce our next speaker, Dr. Gerard Gioia.
Thanks, Bob. I also want to just acknowledge that although I'm at Children's National Medical Center now, I trained at the Children's Hospital, as many of us remember, back in the 80s, then became, Children's Hospital Boston, now is rebranded, which is the term that the administrators love, to Boston Children's, which makes a lot more sense, which it may have been actually before all of that all started. But anyways, it's a pleasure to be here. Although I am not of Massachusetts origin, and I won't use wicked good like Bill Meehan does, I am a Red Sox fan. One thing I will tell you is that I was rooting for the Giants when the Super Bowl came along, so I know you'll throw darts at me. Anyway, I see I got a little bit of New York. Yeah, all right. All right, exactly, you're done. Anyways, sort of acknowledge here, so I'm a pediatric neuropsychologist. And just to disclose, I do a lot of work in developing tools. So I'm not sure if it's boys and toys or what the deal is there, but we have some gaps that we need to fill. As Bob has mentioned, we're really looking at what we can do with the younger group to develop tools along the way. One of those tools is a pediatric version of Impact. But actually, at the break, somebody was asking me the question. Another thing that we are developing, and I would like to strongly recommend this, is a symptom scale that parents fill out with their kids, young kids. What we have found, and this is not actually the nature, this is off brand, off color, off whatever, off label. It's a free scale, and I don't know if I made it available but it's the post-concussion symptom inventory that parents give us information on. And we've got some very good data that we're just about to publish showing that its sensitivity and specificity is very, very strong and much better than the younger kids' report of their symptoms. Not that kids' own reports of symptoms are irrelevant, they sometimes can be more variable. And getting good adults that know these kids to tell us about what is different in those kids is extremely important. So let me just put that plug in. What I'm going to talk about today really are sort of expand beyond Bill as the foundation, and then Alex is also a foundation, really some of the foundations of treatment here, and talk about how we want to manage this. I did sort of chuckle when I said to Mark, did I come up with that title of that talk? What am I talking about here? What I'm talking about today is how we manage this injury in kids and what needs to be our focus of it. It's not going to be evaluation. It's really going to be the management side. This is something, now I will also say and disclose that I'm a Tar Heel. And this slide here, Four Corners approach, is in paying homage to Dean Smith, who many of you know, basketball coach at Carolina, to recognize that really when a kid has an injury, there are multiple elements that have responsibility here, both for evaluating, tracking, managing, which means they all have responsibility to be educated and informed, and they have to have the tools in their hands to do that effectively. So that's the backdrop to all of this. The foundations I'm going to move through quickly because I think this has been covered very nicely, which is really, in many respects, and by the way, I am from Maryland, and I know that in Massachusetts, the sport of lacrosse is really taken off. But you may see some bias in my slides here, and particularly with the women's game, which I think is a beautiful game. The foundation, as you're hearing, is really a software injury of the brain, one that we think does, in fact, recover back to normal, but where that neurotransmission axonal system and that neurometabolic neurochemical system is disrupted. Many of you have probably seen this slide before. It's the one you came for, obviously. It is really looking at the perturbations in various cellular functions, including, though, recognizing the reduction in cerebral blood flow. This is sort of the basis that Dave Hovda and Chris Giza put together in this crisis, this energy crisis, and this the foundation to the injury itself. Also, again, you saw this in Alex's slide, how long it takes from recovery to recover. Here's the point in this slide. Recovery varies from person to person to person. There is no cookie cutter management strategy. We have to do this on an individualized basis. It's why our earlier grading systems have been largely put to bed, because it is an individualized injury that we've got to manage and monitor. So what do we do about it once it's diagnosed? And I would like to argue that it is activity management, and along with that, symptom monitoring. We do this in many other disease states. We do this with kids with diabetes. We do this with kids with asthma. We do this with kids with epilepsy. We do this with kids with attention deficit hyperactivity disorder. We are trying to teach kids and their caretakers about what the nature of the problems are, how to monitor that, and how to manage that. The good news with concussion is that kids get better. And I would argue, and I will say, this is a working hypothetical argument, because we still need a lot of research around this, but I would argue that the better that we manage activity and we monitor the symptoms, the more effective kids recover. This is just a quick little paragraph from the Zurich statement, which basically says, the cornerstone to recovery is cognitive and physical rest. Now, I would like to add one more, again, working hypothetical element to that, and that's also emotional rest. I think kids that are stressed about this injury are throwing things into their brain chemically and are having a hard time recovering. We've never looked at that in any great way, so I'm just going to add that to it. But the general principles of recovery, we don't want to take any more forces to the head while that brain is still impaired. We want to, again, emphasize good sleep. Sleep is an essential cornerstone, frankly, of recovery. But then, this is what I'm going to focus on here, is really managing that activity level and avoiding the activities that worsen or produce symptoms. And so again, the three ways that we could argue for exertion here: physical, cognitive, and probably emotional as well. And again, with that neurometabolic, neurotransmission system, impaired system as the foundation ultimately, and managing that so we don't overwork that system. And so what I tell kids in clinic is I want them to do the activities that they can tolerate, and what we do is educate them about what their tolerance levels are. So, when people say rest, and next to that you're talking to a kid, most parents go, really? And most adolescents go, really? And so, it's not all or nothing in recovery. As I say, it's finding that sweet spot of what they can tolerate, and we know that improves over time. So the foci of our management are several. Fundamentally, it's the patient and their family. It is really educating them about the nature of this injury, about the balance between activity and rest, teaching them the concept of sub-symptom threshold, doing activity below the level that your symptoms will worsen, monitoring that symptom level over time. So whereas we might think that rest is a passive process, I would argue strongly against that. This is an active management system that we're really putting in place. We've got to modify the environment and the stimulation and the things that kids, particularly in those early stages, have to respond to. And this is where not only home, but school becomes so critically important. And I'm going to talk more about that in a minute. But also out in the community as well. And then getting to the people in those environments. What do they need to know? We've all, as clinicians that have worked with kids with this injury, will send them back to school, and that school may be more or less educated about what this injury is. And we have kids saying, my teacher doesn't believe me, they think I'm okay, my head is killing me. Well, that's probably a teacher who's undereducated about this. And so we need to work on that, and I'm going to talk a little bit more about that. I also like to think about this because, as it was said before, a concussion is not a concussion is not a concussion. No two concussions are alike because no two individuals are alike. No two histories are alike, and probably no two force profiles are alike. What we also know is that there are different stages in the recovery process. And within that, we build varying supports based on that stage. So we have the early stage, certainly in that very early 0 to 3 day period, where probably that neurometabolic crisis, that energy crisis, is at its greatest. And then we start to look at the, quote, typical recovery. Most kids will recover over a matter of days to weeks. And then we've got the group of kids that have this prolonged recovery. You'll be hearing some about that this afternoon, and I'll give a little snippet of some thought about that. And these are kids that require more issues. But number one, we know that we do a lot of active rest in those first 3 days. We try to recommend kids not go to school if that can happen. We try to recommend that they not overstress. The texting and the computer use and all that sort of thing is reduced. We also then look physically at, again, as they're recovering over time, looking at that sweet spot and seeing what they can tolerate physically. Those kids that have the atypical trajectory, though, that prolonged recovery, we're now starting to think about things where we start to introduce sub-symptom threshold aerobic activity that may have benefit on a number of different levels that I'll talk about in a minute. Cognitive activity, again, first few days, near full rest. Near, I say. All right, because every injury is not the same, and you need to know what are those tolerances. You are caging animals when you are actually asking them to do nothing, and they are capable of doing some things, and we've got to be careful about that. And again, same thing in that typical trajectory there. You want to graduate that cognitive activity as their symptoms allow, in other words, tolerate. And then a similar sort of thing even in the atypical recovery. And then the emotional support side, which is hugely important. Half of what I do in my clinic is to establish a trusting relationship with that kid and family, let them know that I am on their side, that my goal is the same as theirs, and to support them. And that generally is an effective thing in the typical recovery. But in the atypical recovery, we oftentimes have to become therapeutic now because these kids are getting depressed. They are really upset about the fact that I can't go with I have a senior who can't go with her graduating class right now because she is so symptomatic, and this is the end of her high school career, and she's being restricted. Just to sort of mention, so what is this exertion thing? Because again, this is what ultimately we're trying to manage. So it's vigorous action or effort, it's physical and mental exertion. What is cognitive rest? I would argue it's on a continuum here from no activity to full rest to full activity, no rest. And again, where are you on that continuum, and where is the sweet spot as tolerated? That I think is an important message here. So when we say managed rest or managed activity, I don't care what it is, they're two sides of the same coin here. And in reality, there probably is no such thing as no cognitive activity unless you're comatose or asleep. Some might argue some 14-year-old boys. I'm not sure about that, but anyways, the therapeutic limit, I would argue, and again, this is a working hypothesis for those of us who want to do research. Let's start looking at this very directly, is to limit that activity within the sweet spot so that it is sub-symptom in its threshold and it does not blow out your symptoms. That's really what we're trying to work with. So I'd argue that. So one of the things that we've been doing over the last number of years in our both clinical and research program is to look at developing a quantitative metric for exertional activity. And what we do, we adapted, if you look at that top line, that's the FACES scale for pain, right? Well, I had an artistic postdoc that took the other three symptoms, these basic four symptoms, and created FACES. And basically, you're asking a kid at the beginning of a cognitive session of testing, what are their symptom levels, and at the end of that session, what are their symptom levels. We use this to look at how sensitive that brain is to that exertional activity, and we use it to teach the youngster about symptom management. These are the things you need to be aware of. Look how your headache goes up. Look how your fatigue goes up. Look how your concentration is starting to obliterate. It's not working well because you've got this amount of tolerance to put in place. We've also said, well, what's the base rate of this problem? Without this injury, so we've got over 1,000 kids, normal controls, where we ask them the same question at the beginning and at the end of a cognitive test. In this case, it happened to be the computerized test impact. To what extent did their symptoms change? This is literally a difference score between the beginning of the test and the end, and you can see that very little difference in those exertional phenomena. In other words, kids generally don't become more tired. They generally don't spike headaches. They don't have their concentration affected. But here's our group of concussion kids, and now, so two things. Number one, look at the differences between boys and girls. Girls report a much greater difference in their exertional activity than boys, but both are elevated relative to controls. So again, we think this exertional phenomenon is a very important component in addition to the score on the test or their symptoms over the course of that week. And so where are we going to look at managing these issues? I would argue that it's the physical activities, the recreational activities, the things kids love, and then the kids, their school learning. Both, again, the physical and the cognitive activities. I'm going to take a couple minutes here then just to talk about some of the work we're doing in schools because this is the laboratory. This is where kids go back. This is their job, right? They are learning, they are acquiring new information, whether it's academic material, whether it's learning about how to get along, or practicing incompletely learned knowledge, i.e. the dreaded homework, right? And the bottom line is there is vigorous mental activity that's required, and therefore you are putting a neurometabolic strain. You are asking that brain to transmit electrical activity across, and so we've got to manage that. I like this statement here because many times I say to the families, particularly of those hyper-focused, hyper-achievement-oriented kids, I say, your number one goal is to get better here because you are not going to be helping yourself in your studies if you don't get better. So Jocelyn Elder said, you can't educate a child who isn't healthy. And you can't keep a child healthy who isn't educated. And frankly, that second part probably goes for the parents and for the teachers as much as it does for the kid. So in your, on your little drive, I put this paper in there, which is a paper we published about 4, 5, 6 months ago, looking at these issues of school and the concussed athlete and the kind of recommendations we make. And so some of the things that I'm going to be talking about are in that paper. So I think, both in terms of how the concussion affects school learning, but I also think about how school learning can affect the recovery from that concussion. Both of those are important. Here's a study we've done, and again, are putting together, where we asked 80 kids, what are the kinds of problems that you have? And these are kids in clinic, they reported an average of 4 of these problems, not just 1, but 4. And those are the percentages of that group. So you can see that headaches interfering with their schoolwork, can't pay attention in class, homework taking much longer. So these are real issues that kids were reporting. Also, we were asking them, what are the particular classes that you're having the most trouble with? We asked parents and we asked the kids. First of all, parents, 25% of them said, my kid's not having any problems in any classes. Kids said, well, maybe so, mom and dad. But interestingly, math was blowing these kids out, 3/4 of the kids. And these are not kids with problems with math, but the mental calculations, the multi-step directions, the things that really demand those executive systems were a challenge, and you can go all the way through. So I basically tell the art teacher, you're basically the treatment site for concussion, right? The art room. This is also some work we were doing looking at that exertional phenomenon in kids that came into clinic, 72 kids. This is a different sample where we asked them, to what extent have your symptoms worsened over the last several weeks? And what you can see is this is a sample of kids. 80 to 90% over that first month said that their symptoms were worsening. The bottom line to these things is just the foundation that we need to manage these kids' cognitive activity in school. So the other piece of this then, though, is we need to prepare the school to receive the kid, to support them. And this is where our latest work with the CDC is going. And actually the American Academy of Pediatrics and Mark Halstead, Kelly Sarmiento at the CDC is organizing a group to really bring together some very concrete ideas and recommendations for schools in supporting kids in returning. In our paper that we wrote, we give some recommendations for what schools can do before the season, so to speak, before the school year, to develop academic management policies and also to develop those skill sets that a team, who are the people at your school that are the team? The health folks, the guidance counselor, the school psychologist, the administrator, maybe a couple of key teachers and coaches that really are that team that understands and receives and consults with those teachers when the kids are returning. And what are those strategies that are used? So this is the table. Alex showed some of this earlier, but this is the table in that paper that you have on your flash drive that goes through the kinds of problems that kids can have. And this is only half of the table, by the way. We have another whole half of it. The kinds of ways that it can manifest in school and the kinds of supports we put in place. Obviously, I'm not going to go into depth in these right now, but the point is we have ideas, working hypotheses. We think they can be effective with kids. We need to put some of these things in place. Obviously, we then think about returning kids to another important activity, which is the fun part of life, their sports and recreation. And you've already heard this again from both Alex, you've heard it from Bill Meehan as well. The bottom line is we return kids to physical activity that has a risk when they have no signs or symptoms, when their neurocognitive function and their balance is back to normal, and we have basically put a stress on that neurometabolic neurotransmission software system to make sure that these symptoms do not return. And as our state laws say, they are cleared by an appropriate medical professional before they go back to these activities. Then we get to this issue of the graduated return to play. Now, again, this is the same argument, I would say, the graduated academic return to play, so to speak. On the playground, though, or on the fields and the courts, our challenge is how do we do it? I mean, and I'm talking about specifically what do we do, how do we do it, and who does it? I don't know how many of you hang out with 8-year-old soccer players, but they typically don't have athletic trainers on the sidelines, which is a huge problem. I'm the biggest fan of the athletic training community, and we need more in all of our sports, and especially the youth sports. So we've been looking at sports-specific guidance that would be medically directed, that would be for football, guidance for soccer, for ice hockey, for lacrosse, for rugby, for basketball, for field hockey, you name it. And of course, it goes through, and you can't read this, but basically through our steps, right, of increasing that exertional activity, blood flow, movement, sport-specific activity that involves cognitive activity, down to the point then of some controlled contact to be sure they can handle that. That is not a simple process. And one of the things we've got to think about is how we prepare our communities to do this effectively. And that brings us then to providing the appropriate guidance and clearance for this. One of the things we've done in the state of Maryland is to develop a two-step clearance. One is to clear them for the gradual return process, and the second is for the final clearance once they have proceeded through that graduated step. And again, some of those forms are on your flash drive as ideas for that. But again, what we know is that these have to be done effectively in order to safeguard kids. So I want to just take a quick moment and talk about a protocol, and I don't know if this will be addressed at all this afternoon, Bill, in your talk, but again, looking at some of the slow to recover kids that are now 3 to 4 weeks post-injury with prolonged symptoms, and some of the work that's been done. The two groups that have published some some initial papers. Isabelle Gagnon at Montreal Children's and John Letty and Barry Willer at the University of Buffalo. Really the idea being that, again, if we think about those stages of recovery, in the typical recovery pattern, rest actually, moderated rest, managed activity, works pretty well. But we have kids that, for whatever reasons, and ones we still need to understand, seem to have these persisting symptoms. We cannot keep them stagnant for probably a lot of reasons, some of that psychological and some of that physiological, but we also can't go back to full activity and full risk. And so they've been putting together some papers and some ideas and developing, this is basically a log that we have kind of come together and developing for kids that identifies, whether in a clinic or in a home-based program, the kinds of activity that you do, the level of activity you're doing, again, pre-post symptom assessment, knowing where that sweet spot is, and really building an activity level that begins to stimulate endorphins, maybe brain-derived neurotrophic factor, other kinds of chemicals that we think may be helpful for that brain's recovery. We actually, this comes from Isabel's work looking at an effort scale or an activity scale, really, and really guiding kids, saying, I want you to start with this just feeling a strain, at 4, and I want you to do it for 10 minutes. And so we literally can, give them the effort. You're going to do a 4, you're going to do it for 10 minutes, and it's going to be, riding a bike or something, a stationary bike. And you build that and you monitor it. And again, you find out what is that sweet spot of physical tolerance over time. All righty. In my last 5 minutes, just to give you, and again, a lot of these things are on your flash drive, some of the tools that are out there. Acute instructions, what do we say at the point of the injury or in the first few days to parents and to schools? What are some of the post-acute prescriptive instructions and so forth? So we, through a study we did with the CDC looking at the emergency departments and what they do and what instructions they give, developed this discharge instruction called the homeschool instructions, the post-concussion homeschool instructions, which basically what we were trying to do, it's somewhat of a busy form. So what we did is gave these bands of, these are the major points we want you to know when you go back to the ER. What are the kinds of danger signs you're looking for? We're using the same kind of terminology that we use in all the rest of our CDC materials. What are the common signs and symptoms you should be monitoring? What can you do in your daily activity? What are the do's and don'ts? And so forth. And then one major thing, when do you go back to school or not? And what should they know about? Again, giving family some out-of-the-box guidance on what they should and shouldn't do. I'm sure we've all heard the stories. Concussion happened in football, but it's okay for them to go skateboarding. Really? But the family wasn't guided. These are people who love their kids, but they were not guided as to what they can do and not do. Then the post-acute. So now we start to think about how do we manage this for that symptom pattern and profile for youngsters. Now it becomes prescriptive. And these are some materials that are on the CDC website, the Acute Concussion Evaluation Care Plan, or the ACE Care Plan. Again, giving the clinician some guidance as to what they do. The purpose is to educate and to manage that activity level. And then we've got some very nice materials now on the CDC's website that give school guidance. We have a 12-page guidance form that is quite detailed, and I really encourage you to jump on. They're all PDF and downloadable materials to help you there too. I'll give you a little glimpse. I gave a glimpse of this, I think, a year ago that we're doing, again, to use some technology here. You remember that form I showed you before where we teach kids here to do some exertional ratings? Well, we want kids to walk into school and to walk home and to do this. So we're thinking about putting this monitor system onto a smartphone where we can have them at the beginning of the day rate those symptoms. We can then periodically program it to rate those symptoms, and when there is an excess level, an alert comes up, and that alert will also either text page or email the nurse or whoever, again, that school defines as the team the concussion team. Kids don't always want to pull themselves out of class. Sometimes they need help, but we really need them to be partners in their recovery. So the bottom line summary, and I always start from the bottom up, I'm not sure why that happened, is that we really, again, think of neurometabolic, neurotransmission deficits, the software problem, as the foundation of our management and our treatment. And I really think of this as active management. This is not passive management as we're trying to help kids recover and get back to life. And it has to happen across all the domains of what they do. That whole as tolerated phenomenon is important. And what we do, of course, is then to find that sweet spot and gradually increase those levels of activity in the academic and the physical and social areas. Again, active research is starting to look at this whole idea now of sub-symptom threshold activity programs for those folks who are prolonged in their recovery. We need, obviously, some more work. I think what we have now, again, are working hypotheses. And again, there are a variety of tools out there. The CDC website is really a nice place. If you've never been there, cdc.gov/concussion. It's a library of materials. And they're out there really to help not only educate you, but educate your schools, educate the medical community, educate coaches and parents, educate kids about this injury and ultimately its management. So I'm going to stop there and thank you for your attention.
So that was just I think a beautiful summation of concussion. We are not done with concussion for the day. There's going to be a lot more coming up after the lunch break. But we want you all, using Dr. Gioia's metric, we want you all to keep those happy, smiley faces in your concentration. So we're gonna move to some spine injury. If we can get to the switch over to the slides here. So I'm going to be talking about the cervical spine in the athlete, and Dr. Demacourt is going to follow with the lumbar spine. And obviously, these are fairly important topics. As a spine specialist, I like to think of the head as being there because our spine would look really funny with that one on top of it. Obviously, I think it's more of a top-down approach, but so you see very unhappy patients if their brain's working fine and their spine isn't. These injuries can be very serious. So if we look here, sports-related injuries are the fourth most common cause of spinal cord injuries, but they're even disproportionately affecting kids more than adults. So if you look, it's an average age of 24, and it's the second most common spinal cord injury in patients under 30. And somewhere in the range of 2 to 10% of cervical spine injuries are related to sports. So it's not an insignificant cause of neck injuries. Because we have a pediatric focus, just cover a few things in very brief detail. What puts kids at even higher risk? Well, there are subsets of kids that are going to have congenital abnormalities like Klippel-Feil syndromes, which are congenital fusions. And here's one where you can see a fusion at the top and a fusion at the bottom, and it'll put a lot of stress on the levels in between. Kids like this essentially are going to be eliminated from sports. A lot of you, if you're pediatricians, will be dealing with Down syndrome, and Down syndrome has a component of C1-2 instability. They have very lax ligaments, and you might know that before participation in things like Special Olympics, they usually get flexion extension films. And that's something we have to keep an eye on. Only about 1% of them ever come to surgery, but it's something that's going to be far more common in a pediatric practice than you'll see in an adult practice. Abnormalities of the odontoid, the top bone of the spine, also relatively common congenitally, and a lot of these kids will present with neck pain or the like. And then Chiari malformation, we could have the whole course could be the Chiari course instead of a concussion and spine course. It's a huge topic. I would say most Chiari malformations do not affect your ability to play sports and are not symptomatic, but there's a wealth of information and a lot of negative information out there about Chiari malformation, so I won't cover it in this course, but these are just some things we'll always look at in the pediatric practice in spine patients. What sports cause spine injury? Well, a lot of them. Diving and surfing are very common. Surfing is more common than you'd think. It's a soft sandy bottom, and yet the waves are pretty strong. Diving, it's mostly just, people just don't realize that the water is not going to stop you nearly enough to prevent a spine injury. Skiing, football's, this is mostly because you weren't doing something right. So in football, it's mostly because you were using your head as a weapon. But in other injuries, such as ice hockey, it's usually not because you're using your head as a weapon, it's because you weren't prepared for the hit. And that's why things like boarding are now penalties, because it's the unprepared player that's hit from behind that's going to suffer this injury. Gymnastics, and I don't have cheerleading on this list, but I consider that sort of like unsupervised gymnastics, is very high on the list. So if we look here, this is just among football, and football always seems to get picked on, but it's because there's so many people playing football in our society. So if you look early on in the 1960s or so, these are sort of rates of catastrophic injury. In other words, paralyzing injury. So why did they go up? Why did they almost double? Well, it has to do a lot with the question that was asked before. It's because there were good helmets, right? So now you feel pretty confident about using your head as a weapon, but your neck's no stronger than it was with the weak helmet. And the neck, it just bends under the pressure. And then head-first contact was banned, and we saw it drop to 1/5 of what it was, right? So no doubt, rules changes can make a difference. I mean, we've seen it in neck injury, and I think we will see it with concussion as well. And, interestingly, if you look at football, it's the bigger, faster players that are more likely to get hurt. Counterintuitive, right? They're in better shape, but that means they're hitting harder. And there was one study that's a sort of an older study now, but they took x-rays of all people entering a Division I football program, and 32% of them already had signs that they had injured their neck without really knowing about it, but injured their neck at the high school level. So your neck can essentially fail in several different ways. The most common one in sports is this. It's a flexion injury. You put your head down, you flex your neck, and then you hit the top of your neck, and that's going to cause the injury. Extension is relatively uncommon, but I've seen it. I've seen it in a wrestler where they got hyperextended when they were thrown to the mat. This you're not really going to see in sports. This is sort of like the person jumping out of a window for fire or something, and they land and have a lot of loading. And this is what we call a chance fracture. This is really what you see in car accidents alone. So it's a seat-belted person who the car stops rapidly and the body keeps going forward, and the seatbelt causes the fracture. So we'll look at these now in a little bit more detail, the types of athletic cervical spine injuries, from sort of the more benign ones to the more serious ones. And I'll just go right into it. So nerve root and brachial plexus injuries, essentially we're not really talking about a spine injury at this point, we're talking about a nerve injury. So the brachial plexus is the group of nerves after they leave the spine, or you can get it at the level of the nerves. And a lot of football players will report this as stingers or burners. They know all about it. They've almost all experienced it. It's one arm, short-lived, and generally you'll just keep them out until they feel better. And this is some of the mechanism. So essentially, if you just stress the brachial plexus here by stretching, and it's usually because your head's going one way and your arm's going the other, and some people, I can make myself feel that burn when I do it. That'll cause it. It'll happen if you have direct pressure onto the brachial plexus. So you see an example here, very big trapezius muscles. So the pads rest on the muscle instead of the bone. That'll cause it. It's not a big problem for me, but I bet Dan LaCouture here, he probably would experience it. He's got very big trapezius muscles, and a lot of pads don't fit right in that case. And this mechanism here is just you bend the neck so much that you crush the nerve roots as they're leaving. So that's generally a fairly benign thing. You get them back to play as soon as they feel well. If it is really repetitive, you can get permanent nerve injury. Cervical sprain. So what is this? Well, this is basically the athlete or non-athlete, anyone who experiences neck pain, right? They somehow hit themselves and have neck pain. So what do we call it? Well, in the absence of anything else, we'll call it a cervical sprain. It's scary because you don't know there's the absence of anything else until you know that they're fine, right? So someone could present with neck pain, and it could be that they just strained a muscle, or they may have torn a ligament, they may have broken a bone in a subtle way, And that's why we're so cautious about keeping an athlete, their spine immobilized, putting them in a collar, not clearing them until we know more. And this is all going to be covered in this afternoon's session on on-field management. How do you manage the athlete on the field when they've had the injury? Eventually, if they're doing fine, they're going to get back to full play. But if someone has neck pain, I think the point is you don't know if they're fine or not. You don't know if they have a serious injury or it's a not serious injury. And this is a case I like to use just because frankly it's so scary, of a gymnast who just hit her head in the pit. You know, she was doing a move, went in the pit, normal thing for her. And she's very competitive. She was a ranked gymnast. And all she had was neck pain. And this x-ray is normal, right? Is there a finding on it? There actually is, but you couldn't make that finding from this or from the other films that were done that day. But she had neck pain and she was appropriately kept in a collar. And if she wasn't, she probably would be paralyzed, because a week later, the neck is not so good. She's starting to slip over here. And now she's presenting with a neurologic deficit. So what just seemed like a simple neck sprain was really a fracture, and now she's having injury. You sort of see a little bit more of the subluxation here, but then on the CAT scan you can see she had fractured her facet, but it was so subtle that you couldn't see it on the x-ray, and yet it was so unsubtle that within a week her bones started to slip, and here you can see that fracture through there. And she would have had really quite serious, potentially paralyzing injury if not presenting for further care. So we went and we fused her, and we specifically, for those that are neurosurgeons, say, well, why'd you fuse her in the front? And it was because we wanted to limit her to a single level fusion because she wanted to get back to gymnastics. And if you fuse more than 2 levels in a spine, you really have to take them out of high impact sports. So can she return to play? I mean, I wouldn't, but it's because I look funny in one of those tights, I guess. But she did. I mean, she went back to sports. So herniated discs, these are fairly common with repetitive axial injury. They're in the neck. They're not that common in kids. In fact, I have not, in my 15 years at Children's Hospital, had to do a herniated disc in the neck of a child. Now, lumbar discs are very different. We're seeing more and more of those in the athletic population. But the treatment for herniated discs in the neck, again, you're probably not going to see them in a kid, but you will see them a lot in adults. It's often non-surgical, and most athletes are going to be able to get back to play after its treatment, be it surgical or non-surgical. And this is an example here. You can see a herniated disc up at this level, and just with physical therapy, it goes away. This was a rugby player, and she got back to play without any problem. So herniated discs, if we had to operate on that and take it out, they'd still be able to get back to play. Transient quadriplegia. So this is something, it's a very scary thing to see, but not infrequently it happens. I mean, we see, I'd say no less than 10 to 12 kids each year, probably even a little more than that, who they were playing, they made a hit, and they were just down. Like they couldn't move, they couldn't feel, and it starts to come back rapidly. Rapidly could be seconds, more likely it's minutes. It's almost always within a day. So why does this happen? Couple of theories on it, but probably the most prominent one is just that especially in a young person, the ligaments are so lax that you can really reach an extreme of flexion or extension, get a little pinch of the spinal cord, and then come back to completely normal alignment. So that people will call it, if it's permanent, they'll call it a skiwara, for spinal cord injury without radiographic abnormality. But if it's transient, you just call it this transient quadriplegia. You could also, the other theory is just a stretch injury, so that things sort of stretch out and then pop back. So here you have a 15-year-old wrestler who basically went down. It was an extension type injury in his case, and he had a temporary quadriplegia. He couldn't move, couldn't do anything. Started to come back relatively quickly. He was taken to the hospital. Normal x-ray, and again, it really is truly a normal x-ray. We get an MRI scan, normal MRI scan, and that's usually what you'll see in a young athlete. is that it's normal, and you have a little trouble explaining why did they have this. Now, in an older athlete, it is less likely to be a normal MRI. So it's a sort of a different entity in youth than it is in adults. There's a nice article that we put in the literature section on spine that came out this year on this process, and almost all kids with this have normal MRIs, normal flexion extension films, and can get back to play, and it almost never recurs. So it's a very interesting phenomenon. Now, if the MRI were not normal, if there was a herniated disc, some stenosis, something like that, it's a whole different ballgame, right? We got to decide, was there something about that child's anatomy or that athlete's anatomy that made that happen, and should they not go back to play, or do they need treatment before they can go back to play? But this is a scary phenomenon, but one that usually gets better on its own. Spear tackler spine, it's something that we should certainly cover. Really, it is a football phenomenon again, and there's someone here from the NFL today, so I don't want to just pick on football, but this is specifically because football is the only real tackling sport in that sense. It's something that you see in football. It's a developmental change over the spine, so that they get degenerative changes that cause stenosis. They lose the normal alignment, and like that study in JAMA, a lot of them will have prior X-ray abnormalities, or when you do an X-ray, you see prior abnormalities. And then, because a lot of these are professional athletes, you document spear tackling techniques, and most people, if they have this, they would get pulled. It's a very high risk for injury, and sort of here it is graphically. So normal alignment of the neck has a nice gentle curve to it. So if you have that curve, it really protects your neck. The force is not directly transmitted. As soon as you put your head down for that spear tackle, you straighten out the neck, and any force to the top of the head goes right down the spine, and then you can see this depiction here of how that will cause the spine to fail. And that's why it's the bigger, stronger athlete that's going to have this happen to, because they're going to be hitting with so much force when they put their head down that their bones are not necessarily that much tougher than anyone else's. They're just much stronger otherwise. So here again, cervical stenosis. If you've got someone who's got this degree of stenosis, and then they've had any degree of neurologic compromise from a hit, this is someone you really have to think seriously about. Do they get pulled from play, or is it something we can treat? Is it just a local level of stenosis here that we could then do a surgical procedure on to make it better? So fractures and dislocations, these are the most common cause of the really bad injuries. And again, it's the well-trained professional athlete that's going to have this happen. They're hitting hard, and they're hitting fast. So this is a youth athlete, a 15-year-old, who presented paralyzed after making a tackle with his head. He led with his head, and we get this X-ray, and you sort of have a suggestion here. If I was showing this to my residents, I'd say, what's wrong? Well, what's wrong? It's not an adequate film. You want to see everything, so you got to pull down the shoulders, right? But you can see a pretty good fracture over here, and in this guy's case, it was a paralyzing injury. So we rushed him to surgery because we wanted to decompress the spinal cord. We got the CT first just to see the anatomy better, but you can see he's fractured through that bone. He's markedly compromised. His spinal canal, was taken to surgery. We got an MRI after surgery. We didn't want to delay an operation with doing the MRI, but pretty good contusion to the spinal cord. And ultimately we got the bones to heal, but you can't make the spinal cord heal, right? And he has made a reasonable recovery. And for those of you who have been at prior courses, this is a patient of mine, Jared, who spoke at last year's course, and he went from being completely paralyzed to going out and doing the coin toss for the Thanksgiving Turkey Bowl game at his high school. He's one of a set of triplets, two of whom have had this same injury, and the third one is still playing. Unbelievable. And set the state record last year in honor of his brothers. For yards returned. But these are tough injuries. That's what I'm saying. It's if your brain's working normally and nothing else, none of the signals are getting through. These are very, very sad cases. This is just showing flexion extension film. So we got everything to heal, but we can't undo a spinal cord injury. We still don't. We're not even close, I would say, in that technology. Looking at vascular injuries to the neck. Relatively rare, but you do see them in sports. You could see occasionally laceration. Hockey is the sport where you're more likely to see that. A very dramatic case a few years ago of a skate coming across the player's neck and just blood spurting out on the field, and did great. I mean, someone got to him right away, sewed it up in surgery. Dissection is something you're more likely to see. We'll go over it a little bit more. So these are just some images here showing how these vessels traverse up through the neck. So come off the aorta, you have the common carotid artery and the vertebral artery. They come off a little differently on either side, but all four of those arteries need to make it up to the brain. Probably some people can lose some of them without a deficit, but if you lose, say, both carotids or both vertebrals, you'd be in a lot of trouble. So arterial dissections tend to be from stretching of the vessel somehow, blunt trauma to the vessel, and essentially the vessel's intact, but the inner lumen of it is not, and the blood's no longer getting through, and you often will present with signs of a stroke because some part of the brain is not getting adequate blood supply. This was a case from this fall. He is an athlete, but this was suffered in a motor vehicle accident, and you can see a relatively complex fracture that goes up through this area here, and he's a little slipped. But the thing that got us more concerned, and it's a little hard for me to see this exactly from here, but this is what's called a CT angiogram, and we have his carotid artery here and his carotid artery here. Here's a normal vertebral artery coming up through the bone, so the vertebral actually goes through the bones. And if we look here, I hope I'm pointing in the right place, it's a very diminutive vertebral artery, and then it stops. So it stops completely at the fracture. And had that happen on both sides, it would have been fatal. So in this guy's case, he was fine. He literally, we would not have known a symptom of this, but we had to anticoagulate him because he's going to be at risk for throwing a stroke. And then we operate on him, and we operate on him from the front. Again, if you're a spine surgeon, you'll say, gee, the injury's in the back. Well, we were very scared of putting any screws near the other vertebral artery, because if we then took the other vertebral artery by a bad screw placement, we would have killed him. So we stayed up in the front, and he healed very nicely with just that operation after a few months. Can he return to sports? Sort of an ironic question. No. It's he could do certain sports. I mean, he could do non-contact sports. You can live on just 3 of your 4 vessels, but there's no way we'd let him back to a contact sport, because if he had another injury that hit his other vertebral artery, he would not survive it. Now he's down to 1. A couple of things just to cover briefly, because they are talked about, and we had at one of our conferences a few years ago, we covered this in a little bit of detail, the role of hypothermia. And we actually had the surgeon that operated on the football player up in Buffalo. And the long and short of it is there is not good data to support hypothermia. It doesn't mean it won't work in some individuals, but even the surgeon, the neurosurgeon from Buffalo, did not think hypothermia played a role in that individual athlete's case. He said the athlete was getting better before the hypothermia began. And there are a lot of complications to hypothermia. So in using head injury, final study, the 4th study finally came out. They all showed the same thing, that head injury patients treated with hypothermia did worse. I mean, it's unequivocal. They did worse. And they did worse because hypothermia has a lot of other effects on the body. So although there are definitely reasons it might help, I mean, if you could just by itself, you can cool the brain or spinal cord, maybe that'd be great. Cooling the whole body is not so great, and the complications seem to be higher. Steroids, sort of a similar thing, right? We all think of steroids for spinal cord injury, but all the position statements that come out of organized neurosurgery are that the side effects of the steroids are worse than the benefits of the steroids. It's not to say you can't use them, but no one would want you to think it's the standard of care that you have to use steroids or you have to use hypothermia. In fact, you tend to do potentially a little bit worse if you use those things. So just sort of summary here, these injuries classified into three sorts of types. If you have a permanent spinal cord injury, can you get back to play? No, you really can't. The risks are too high. It's, if we talk about the brain being susceptible after one concussion to another concussion, the spinal cord is even more susceptible. Think of the volume of the brain is about, in a normal individual, about 2 kilograms. The volume of the spinal cord is 1/10 of that, and still has almost as many neurons as the brain, right? So you don't want to take a chance. If you have had a transient spinal cord injury, but everything's normal, like the case I showed, especially in kids, you can almost always get back to play. You do not see that repeating itself, and we've never seen a kid, unless they go on to break their neck, we've never seen them then suffer a catastrophic injury. So even though you had it happen once, it's not likely to happen again, and it's not likely to do anything real bad. And then the much more common thing is, well, there's something wrong radiographically, but a normal exam, and then it's like concussion. It's got to be individualized. There's no cookie cutter sort of approach to that, and we've got to look at each one individually. So in summary, I'm a big prevention guy. I spent a couple of years at the head of the National Injury Prevention Foundation, they're called Think First. Preventing these is by and large the best thing we can do, because we have really pretty poor treatments for spinal cord injury. So the rules changes you saw cut down the injuries in football by 80%, and I think knowing these things is important. Knowing not to dive headfirst into a pool, knowing that body surfing is really bad, very important. For management, you'll see more of this afternoon, but immobilization is the most important component of management, and return to play sort of needs to be an individualized basis, especially if there's any real abnormality. Thanks. And now to discuss the lumbar spine is Dr. Pierre Demacourt. Dr. Demacourt is a member of our sports medicine department here at Children's. He is really what I would consider one of the premier experts in lumbar spine. I mean, I will go watch him in clinic just to figure out some of these diagnoses myself. And about every body part except my lumbar spine is a patient of Dr. Demacourt's as well. Load up a talk here. This it?
It's lumbar.
Top. There we go.
Great, thank you. I'm one of those unfortunate individuals that ended up going over to Fenway because I didn't read my instructions properly, and I don't even remember getting a concussion. So I'm going to talk about the southern end of the neuroaxis, where I spend a good part of my day, and I have no disclosures. What I'm going to do is basically go through some of the epidemiology of some of the sports that we commonly see, and then I'm going to go through some of the biomechanical risk factors, because this really focuses on kids. We'll talk about the exam, because I think that's an important part of sort of differentiating what we have. And then finally, I'm going to go into some of the specific diagnostic entities, particularly spondylolysis, and I'll try to give you some updates on where that is right at the moment. So we know that back pain in kids is a fairly common thing once you hit the age of about early adolescence. At the age of 7, it's very uncommon. So your whole suspicion should really go way up if you have a kid at the age of 7 with back pain, and that's when you're going to start to kick into working them up at a fairly early age. But by the time they reach 17, 18, they're almost at the incidence basically and prevalence of the adults. So it kind of falls into many of the categories that are very similar. The epidemiology of back pain has been looked at in sports. Kujala and his associates have shown that it's significantly more prevalent in athletes than in non-athletes. And if you take a look at certain sports like gymnastics, Garrick reported up to 43% of gymnasts actually complaining of back pain. And if you take a look at different reports, it ranges anywhere for spondylolysis between 5.9 and 32% in gymnastics. And I always look at gymnastics as sort of that really extreme motion sport where kids get into trouble. And in fact, if you look at an early study back in the 90s by Goldstein, he looked at MRI findings of gymnasts. And if you take a look at the pre-elite, the elite, and the Olympic level athletes, it goes from about 9% to 43% to 63% of changes that you see on the bottom right-hand side there, where you have different discogenic atypical Schurman changes in the upper lumbar spine. And I'm going to come back to that when we talk about some of the specific diagnostic entities. So there are certain things that cause the problem in gymnastics, and certainly a variety of landing skills with both hyperflexion and extension can be a significant part of it. But hanging events put a tremendous load across the lower lumbar spine, anywhere between 6.5 to 9.2 times body weight that goes across the lumbar spine. And then in certain positions that you see in the bottom right-hand corner called the halo position, the gymnasts are actually practicing to hold that increased lordosis and thoracic kyphosis, which can add stress and improper positioning to the spine in order for their events. Certainly, uncontrolled extension is a big problem with spondylolysis, and in fact, if you take a look at the most recent studies by Sario and their co-workers, that it's extension and rotation that are the two most significant problems with spondylolysis and applying stress across the back. And if you take a look at like a baseball player with rotation, it's usually the opposite side that gets the fracture from the rotational motion. But in gymnastics, you certainly have a lot of hyperextension type of events. And then if the gymnast is weaker in extension of their thoracic spine or at their hips, they can put a lot of pressure at the thoracolumbar juncture, which may be why they get some of those injuries at the atypical Schurmans, which is that upper lumbar spine thoracolumbar juncture region, which we'll come back to in a little bit. And then Joel and John very nicely described this cross-pelvic syndrome, where you have tight hip flexors, tight thoracolumbar fascia, combined with a weak lumbar muscles, weak gluteus max muscles, which all allows this anterior pelvic tilt, which gives you increasing lordosis and stress on the posterior elements of the spine. All of these kinds of things coming back against you for things like gymnastics. If you take a look at dance, which has some similar types of biomechanics, Michele showed a prevalence of anywhere between 11 to 18% of ballet dancers having back pain, and the lifetime prevalence is about the same as the normal adult population at 60 to 80%. And it's because of some of those maneuvers, such as an arabesque, where they have to hold that in prolonged periods of time, and if it's done with an improper posture, that you can see on the upper right-hand side, which is actually a good posture, where you can see a nice gentle sloping motion of hip and lumbar extension. Whereas if you see in the lower right-hand corner there, where sometimes if you're holding too vertical of a posture, or if your glutes are weak and you have to hike your back backwards, Gelabert and his coworkers have shown that that can be a significant problem with placing that stress at the lower lumbar spine, predisposing those athletes to more stress and stress fractures in that lower lumbar spine. And Grajkovetsky and his colleagues looked at that anterior pelvic roll on landing. So if you land with that anterior pelvic roll, then you really place significant amounts of stress across the lower lumbar spine. It's also been looked at similarly of increasing back pain incidence in figure skaters in both the adolescent and the adult population. So what are some of the inherent risk factors that are involved with this? Because some of these things are clearly more than you see in the adult population. Well, certainly strength is an issue, and you're going to probably see that both in the adult and in the adolescent population. And Nadler did a nice study looking at the collegiate female athlete, showing that weakness of the gluteal muscles was a significant factor involved with low back pain. And certainly in a number of studies that have gone through the years, growth itself, during that adolescent growth period, you're at a much higher risk for all kinds of injuries, but back is certainly one of them. And so one of the things that you can often tell parents is to make sure that they're watching the growth of their kids. And if they suddenly see a growth spurt, then you know that they're at risk and perhaps should be cutting back during those time periods some of their extension type of maneuvers. Because what happens is that, again, Kujala again looked at lordosis as being a factor in back pain. Now, that's in adolescence. So it's important to not extrapolate this to the adult population. And in fact, there's some data to suggest that a lack of lumbar lordosis in the adult population may be related to back pain. But during the adolescence, it is a factor in back pain, and it's probably because what happens is during that adolescent growth period, you suddenly increase your lordosis, which has been well documented by the spine surgeons who monitor this carefully with their scoliosis and kyphosis types of x-rays. And it's because of what they call the pelvic incidence, which is a fixed entity between the center of axis of the hip and the top of the sacrum, and that distance increases during that growth period, which increases your lumbar lordosis. So it's not fixed through life, but it's fixed. It becomes gradually increased during that adolescent growth period. And then Voits himself showed that sports, particularly gymnastics, increases your level of lordosis, where they did several thousand kids at the University of Michigan summer camps, and they looked by photometric analysis showing that they increased their lordosis by number of hours per year participating in sports, and gymnastics was the number one factor involved with that. Then another thing that I think is important to understand with all of this is that there's this whole hip lumbar spine interaction. I think in order to properly take care of the spine, you really need to understand that whole interaction process, because lots of times when you have back problems, you have either predisposing hip problems or vice versa. You have the sacroiliac joint where you actually transfer a lot of the forces to the upper extremities, from the lower extremities to the upper extremities, and you can get into psoas problems. And I can't tell you how many times during the middle of the week I'm seeing someone with back pain, and then suddenly it becomes hip flexor pain, gluteus pain, piriformis pain, and I'm sure a lot of you have experienced that on a regular basis. Well, why is that? Well, it probably has to do with there is a small but a very definite amount of motion that occurs at the sacroiliac joint. It's about 2 to 6 degrees, according to several studies by Vleeming and Mooney and their co-workers. And the sacrum is wider anteriorly and superiorly, so that when the sacrum, relative to the ilium, is tipped forward, that's called the nutated position, which is the closed pack or stable position. And during athletic motions, you actually go from a stable position when you're sort of heel striking and landing to a more extended and softer position after you hit the mid-stance phase of running. So there's this constant motion that actually occurs through there. And what stabilizes this, of course, are the muscles that go around that. So you have the psoas muscles anteriorly, which act as a stay of a ship, and probably have relatively less to do with hip flexion than the iliacus muscles on the side by certain EMG studies that occur right there, as well as the multifidi on the back are extremely important to the stabilization, because the multifidi, because of their attachment to the top of the sacrum there, tip that into a nutated position. Well, when we treat kids with back braces and things like that, that's one of the first muscles that gets atrophic, and so it's not uncommon to see kids with a spondylolysis who then suddenly end up with more sacroiliac pain. And I think that in some very rough studies and looking at that, I think it's somewhere about 10 to 15%. We have to formalize that in looking at it. But I think you commonly do see that kind of an association. And then there's, of course, the gluteus muscles that help stabilize the area, and there's a whole bunch of other muscular attachments with the bands that cross the spine to the upper and lower extremities that is a whole different topic in and of itself. But what happens is that when you get athletes that have asymmetric landings, such as figure skaters or gymnasts, then you get this asymmetric roll of the SI joint of the sacrum, and therefore it can cause a lot of problems with sacroiliac instability. So it's an important part of things. And then to further sort of confuse the issue, there's a whole lot of hip things that will confuse you, because 30 to 40% of hip labral tears will present with posterior back pain. So one has to constantly keep in mind what's happening at the hip as well as what's happening in the low back region. So you may start with somebody who you think has spondylolysis, then suddenly they get some more sacroiliac type of symptoms, and they may end up with more impingement types of symptoms in their hip, which is not terribly uncommon in the young athletic population. So now let's talk about the exam that occurs. And so I think the best thing you do is you sort of watch the athlete walk into the room, see what their gait, see if they have an antalgic gait, and then look at them undressed from the rear so that you can actually see any obvious curve that may be occurring there. Look for any kind of skin lesions that might indicate things like cafe au lait spots indicating certain neuroaxis problems. Palpate very carefully along to figure out where that pain is, so you can figure out whether it's more in the lumbar spine or is it more down toward the sacroiliac joint. And then in that same position, you can come down and palpate all along the piriformis muscles too to see if they're actually involved with their level of pain. And then, of course, you're going to go with more of a flexion, thinking more of a disc problem, more extension, more of a posterior element a problem such as spondylolysis, but there's this huge crossover in both of them. And in fact, if you're getting some inflammation of the spinous process apophyses, which I'll show a case of in a little bit down the road, where the young growing athlete just has some growth cartilage irritation of the spinous processes back here, they have a lot of pain on extension, but they also have pain on bending forward. Similarly, sacroiliac pain is sort of the great confuser. It can have pain on both flexion and extension of the spine. But in general, if you have a single leg hyperextension test in a young adolescent athlete that has pain worse on that side, it's a pretty good indicator that that's where their pain is actually coming from. In the seated position, then you can check a full neurologic examination. Is probably the easiest way to go. And then you can do a slump test to see if there's any signs of dural tension, such as a herniated disc. In the supine position, it's very important to sort of remember all those things that are confounders in that hip-spine interaction. You want to palpate the symphysis pubis. You want to start centrally and sort of move your way out, feel the adductors, check for psoas signs, and then you want to make sure that you check your impingement signs, because, again, it's not uncommon. I'd say several times per week that I'm in that quandary of trying to figure out whether something is coming from the hip or whether it's coming from the SI joint. And so if you do the impingement test, which is at that top right-hand corner there where you flex adduct and internally rotate with a compressive force, that will be an indication that something's going on in the hip. Doesn't mean it's a hip labral tear. It can be psoas and it can be a number of other things, but it indicates something toward the hip. But if you're pressing too hard, then you may actually be compressing the sacrum. So what I like to do with this maneuver is to actually do that, but do it with a little extraction so that I'm actually pushing into the labrum, not down into the sacrum, because what that test is if you're actually pushing down, as you see in this top right-hand corner here, you're actually pushing down into the sacrum there, which is the sacral thrust test, which is by several studies one of the most accurate studies for picking up on sacroiliac inflammation. There are a number of other studies that are listed there as well, but I think that the sacral thrust is the one that I typically go most strongly with. Then turning the athlete into the lateral position, you can do a lateral compression for the SI joint. You can check for the tightness of their iliotibial band. But there's a nice position to actually palpate along all the gluteal muscles, the piriformis, to see if you actually have any pain or tenderness right in through that area there. And then in the prone position, you can actually do a sacral thrust, so that what I like to do is to start up in the lumbar spine and push directly on L4 and then L5, see if I get pain right through there, which is a non-specific but sensitive indicator for what's happening in the lower lumbar spine, and then come down onto the sacrum, push on the sacrum, and so SI pain is more likely to be compressed there. But again, you have to take all of your findings and put them all together, because there's a huge crossover again in all of these kind of tests. And then a biomechanical assessment is really a very important part of your exam in the young athlete. So if you're in a hurry, I think the two simple tests are the single leg squat. And so if you can see in this young lady here, she has a sort of that classic sort of valgus collapse at the knee, a little bit of pelvic drop, all indicating a lot of gluteal weakness that needs to be addressed during your rehabilitation process, both the strengthening and with neuromuscular re-education. As well, and this is where you can see a little bit better of a single leg squat right through there. And then the other test is the single leg bridge. And those are two quick and easy tests to do in the office that give you a lot of information about their core strength. I don't do this as much, but you can do the abdominal brace test, which has been validated by McGill, and then one of the very early validated tests, which is also very difficult to do in the office, so I wouldn't say that I do this very commonly, is your back extensor or your Sorensen test. But we have the Concussion Clinic, so if they fall, that's right there. So now we'll go to some of the more specific findings, and so I'll try to spend some time on spondylolysis. We know that kids have a higher incidence of posterior element strain stress, i.e. spondylolysis, that occurs, that it does not occur in the adult level. And so looking at the data of spondylolysis, depending upon the clinic that you go to, you're going to see different reported incidences of stress fractures. In Solar's, which is a Spanish clinic, they see a lot of throwing athletes, and so of course they're seeing a tremendous number of throwing sports. And this is where they actually noted that it's to the opposite side of the twist that you actually end up with increasing stress across your lower part of your back. But they also saw about a 17% incidence with gymnasts, and crew athletes about 17% as well. If you take a look at the general prevalence of spondylolysis, well, it's about 4.4% in the first grade that is non-symptomatic, and then that increases to about 6% by the adulthood and stays level. That's in the general population. Several studies, the Japanese studies, have validated this, but there was a study done with the Framingham Heart Study where they did CTs looking for calcification of the aorta, and they actually showed a significantly higher number of 11.5%. If you take a look at spondylolysis, which is in the young athlete that occurs during that growth period, which is symptomatic, there's been a variety of different treatment regimens that have been recommended, including activity modification, physical therapy, hard bracing, soft bracing, and if you take a look at Klein's meta-analysis in 2009, they were not able to really demonstrate any big difference from any one treatment to the other, but that's because there's probably a bit of a difference in terms of where spondylolysis actually presents. So I'm going to try to just give a story for why I think the Boston brace. I think you can treat it in different ways. I think there are multiple ways to actually treat spondylolysis, but I think that as a method of rapidly getting an athlete back to sports, it's a fairly effective manner. The reason for using the brace, though, is not because it immobilizes the spine. It's been shown that it doesn't immobilize the spine. What it does is it limits extension and it limits rotation, which again are the two things that are most commonly associated with spondylolysis. So the Boston Brace protocol, essentially what we do is we get an athlete and you try to find some acute level of a stress fracture, which is either shown by a SPECT bone scan, not a plain bone scan, but by a SPECT bone scan, or pedicle edema seen on an MRI. At that point in time, if you have a single level that's involved, you might consider getting an isolated CT scan. We used to do a lot of those, and I've cut way back on that, just to give you some relative numbers of ideas of where these things come to in radiation exposure. A plain two-view X-ray is a little less than 1 millisievert. If you take a look at a CT scan isolated to that level, it's almost 2 millisieverts. But if you take a look at a bone scan, it's about 7 to 9 times that. It's about 6 or 7 millisieverts. So it's a fair amount of radiation exposure that actually occurs. So we typically try to sort of minimize that to these young athletes. But anyway, so you make your diagnosis with either an MRI or a SPECT bone scan, and you put them in a brace, advancing that to 23 hours per day. They come out of it for 1 hour per day to do their physical therapy, to do their to showering, etc. They do get some bonus time out. We do allow them to freestyle swim, only freestyle swim, and stationary bike. And we start on a physical therapy program for anti-lordotics and abdominal strengthening. We see them back in 6 weeks, and then we extend them. And if they have no pain on extension at that point in time, and they're having no pain during their activities of daily life, and they're tolerating the brace and doing their physical therapy, then we will continue the brace, but I usually take it off at night at that point in time. Advance their whole physical therapy to full core stabilization, no hyperextension, but we want to activate those multifidi because, as we talked about before, they probably weaken a good bit in the brace. And then it slowly advance them back to sports. And I caution slowly in that they go back gradually to one sport only, that they're having no pain, they persist and continue to have no pain, and that they're doing their physical therapy and wearing their brace. If they get to a point of having pain during that, then we cut them back until they become pain-free again, and then gradually try to progress them even forward. Then we see them back at 4 months, and so at that point in time, they may either be pain-free or they may not be. If they're symptom-free, then we wean them out of the brace over about a 10-day period of time, continue their sports, and really encourage a full gym stabilization program. If they end up for the 4-month mark with no symptoms, then we oftentimes will continue the brace. But the most important thing then is to reconsider what the diagnosis is and consider a limited CT scan. That's the one point where you may consider doing that, because at that point in time you may consider electrical stimulation. So if you take a look at the data for this treatment regimen, it's been anywhere between 80 to 90% effective across several studies. If you take a look at a gymnast study that we did recently in Boston, which was a prospective study for telephone call interviews of 25 athletes that were gymnasts that had been treated. 20 of them responded, and basically they had an 85% return to sports, usually within about a 3-month period of time, with 90% excellent functional results. Interesting, they had a fairly high recurrence rate, though. They did have about a 15% recurrence rate. In terms of imaging, we talked about the CT scan, and the CT scan is probably the best way to prognosticate the outcome of this, because it can either be classified as an early or minimal fracture, one that's starting to separate progressive, or a terminal, very sclerotic fracture that occurs at the later phase, and that's usually a cold bone scan. And if you take a look at looking at this by MRI, it's not quite as good, but it's a pretty effective way of looking at it. And several authors now have actually looked at the MRI, looking at pedicle edema, and shown that it is a prognostic indicator for whether these actually go on to heal. And in fact, Sario looked at the CT scan, at the MRI versus the CT scan. If you had an early fracture on CT scan, that had a very high chance of healing bone on bone, but that if you had pedicle edema, it was almost that predictive. So in a sense, for that early phase of looking at, an MRI really gives you a lot of information as to whether that fracture is going to heal. Same author, Sario, just recently published a study also that does make one sort of compelling argument that maybe a CT scan might be helpful, because if you take a look at the fracture itself, if you had an early fracture, it healed in about 3 months, so 3 months of bracing was probably appropriate, whereas if you had the more progressive lesions, then it took up to 5.4 to 5.7 months to actually heal, but none of the ones that were terminal. I still think you can use the MRI, but you may just have to recognize that you may need to further treat some of these beyond that 3 to 4 month period of time. And finally, I'll just kind of go through the electrical stimulation pathway. There are several reported cases, one by McKaylee, and Penning also had a report of actually athletes that failed conservative management that went on to using bone stimulators, using pulsed electromagnetic force fields, and they went on to full healing. And this was based upon Mooney and Bassett's work, where they looked at fusion in the spine that did show a significant increase using PEMF, pulsed electromagnetic field, in spinal fusion patients. So we did a study back in 2004 using a PEMF stimulator with OrthoFix, wearing this about 3 to 10 hours per day. And it was a fairly decently designed study in that there was randomization into the study. One group was the Boston Brace protocol, and the second group was the Boston Brace protocol with eStim added. And then at the 4-month mark, if they were still symptomatic, they could cross over into the electrical stimulation. We studied 56 athletes and basically ultimately showed no difference in the two groups. But if you went back and looked at the crossover group, the crossover groups did, with low power, show some improvement in healing in all the athletes. None of the athletes that crossed over ultimately ended up needing surgery. And if you take a look at the prevalent data from other centers, it's about 2.5 to 5% that may need surgery. All showed some improvement in bone healing. Only one athlete remained symptomatic, and that was at an upper lumbar. It was an L2 that occurred in a crew athlete. And so if you take a look at the summary of what all that data says, is that I think the Boston Brace is not the only way to treat, but it's a very effective way of treating and getting these athletes back to play in a fairly short period of time. I think that the MRI is a very effective way of looking at these with a non-ionizing radiation standpoint. It will miss some terminal fractures, and you have to recognize that and talk to the parents about that you may have to come back and re-image them with an isolated lumbar CT at a later point in time. And that eStim may play a role in these athletes in terms of if they have persistence of symptoms at 4 to 6 months, it may be very helpful in getting them to heal.